Hepatitis B. So hepatitis B was discovered in 1967, and while very prevalent, the virus still kills an estimated 887 people every year. The most people at risk include healthcare workers, paramedics, law enforcement, teachers, tattoo artists, and hairstylists. It's currently the most common cause for liver disease worldwide, and it is characterized by the inflammation of the liver. So, hepatitis B is considered a blood-borne illness, and while it can be spread by other bodily fluids, it is similar to HIV in that it is spread by microbes in the blood, with a high contamination risk of 30% compared to HIV, which is actually 0.3%. Which means basically if you come into contact of an infected person, it is very easily, if you come into contact with their blood or any of their bodily fluid, it is very easily to pass along. And it is transmitted via sexual contact, blood-to-blood contact, and vertical transmission. Vertical transmission just means that when the mother is giving birth to a child, if the mother is infected, then there's a strong likelihood of the child also being infected with the hepatitis B. But in Western countries and more developed countries, this is thoroughly checked, this is thoroughly tested for, and the mothers are, and so that the children can be thoroughly vaccinated. This is one of the reasons why it is much more prevalent in countries with poor health infrastructure and But, okay, so the vaccine was discovered in 1982, and the vaccination of children works 95% of the time, and about 180 countries have the vaccination of hepatitis B as a part of their national program as of 2006. As I was saying earlier, it's more common in places with poor health infrastructure, which would include Western Pacific and African regions, which in these regions it's most often contracted at birth, which has the highest instance of chronic hepatitis B. So basically, what I've been talking with chronic, there's a difference between the different stages of hepatitis B. It starts with an incubation period of 2 to 3 months, and then that advances to an acute stage, which basically is anything under 6 months. While there's really a very slim chance of complications and it's not very high risk, there still can be complications such as vomiting, yellowish skin, tiredness, dark urine, and abdominal pain, but this doesn't happen most of the time. In fact, it's pretty rare. But after 6 months, there's a much greater likelihood of liver damage, liver cancer, and death. And most of the time, as I was saying a couple minutes ago, there's a much higher incidence in infants than there would be in adults getting affected. So these are children that are infected at birth. Less than 10% of adult cases become chronic, and an overall 257 million cases are chronic in the world. This is a map showing, as I was talking earlier, that sub-Saharan African countries and a lot of the Western Pacific and Asia can fall at risk. In fact, China has a relatively big problem with it. They've improved, but the GIS-based study that I chose was actually based in China, in Shenzhen, and it's a spatial analysis of the distribution of risk factors, and access to medical resources. And while I'll cover that later, I didn't really focus too much on the medical resources access, as the main focus of the study was the correlation between spatial risk factors and the morbidity of the disease. This was published in the International Journal of Environmental Research and Public Health, and it was published on November 7th, 2014. The conceptual design, so as I was talking about a second ago, it was a multi-purpose concept, so it studied many things with the same data, but it was a manipulation of spatial information from hepatitis B hospitalizations to study the spatial risks in relation to hepatitis B morbidity. Morbidity is another way of calculating incidence. It's very similar. Spatial distribution and spatial access to health services. So in this study, the exposure was defined by distance to risk factors and areas of town. The exposure was towards the south and southwest areas of Shenzhen, which happen to be the economic output areas. The study also talked about a difficulty in determining spatial risk factors for hepatitis B. due to the long drawn out exposure period and lack of symptoms. Also, they need access to a lot of private information from positive cases, which is rather hard to get. But from previous studies, they have defined some spatial risk factors in establishments that are especially dangerous, such as bath centers, beauty salons, massage parlors, and pedicure parlors. As in terms of the triangle of human ecology, this study would be considered behavioral, as it presents exposure to facilities of recreation, occupation, and hygienic conditions in relation with the disease. In terms of the methodology design, this is a cross-sectional study which took into account 2,851 hospitalization cases of hepatitis B, as along with their local addresses in Shenzhen, and it used spatial interpolation techniques via GIS and data manipulation equations. So in terms of data collection, the study area encompassed the entire city of Shenzhen, and it was broken up into districts and sub-districts, but the geographic data was obtained by the Urban Planning and Land and Resources Commission of Shenzhen Municipality. Demographic data was sourced from the National Census. The hepatitis B data was sourced from the Shenzhen Center for Health Information, and the service facility data was sourced from online mapping materials, similar to Google Maps, but they don't have that. Here's a map of the study area of Shenzhen, and you can see it's broken up into districts. So they use spatial interpolation, which is the estimation of a value of a continuous field where an infinite field has not been measured, meaning that they're measuring an area where they haven't done specifically. The method that they use is Kriging, and it uses variograms to describe regionalized variables, which was fitting for this data set, and it was fitting for this scenario. The equation below at the bottom of this slide basically details of the prevalence, it details of the calculation using regionalized variables, which is detailed in the graph model in the next slide. So basically going through this model, the nugget is a randomized value, the range stays constant, the CIL allows the range to stay constant, and the points that are relevant are the ones that are farther from each other, which is greater than the range. They also use a correlational analysis method for the correlational part of this study, which we'll be focusing on, and this is the Pearson correlational coefficient, which is used to measure risk factor and disease correlations. This is really similar to what we've been using in class. Basically, if it's close to 0, then it is not relevant. The two factors are not related. Whereas if it's close to 1, then it's positively related, and if it's close to -1, then it's negatively related. So in the results, there was a clear uneven distribution of cases in the south and southwest of Shenzhen, and as I was talking about earlier, these areas are home to really high economic outputs in Shenzhen, and in either of the models below, there will be several models below, none of them were uniformly distributed. So this is just the unprocessed map in Shenzhen of just the cases, and as you can see, they're all clustered towards the bottom. In the compilation of the data, they divided it by the sub-districts, just by number of cases, which could not be used for interpolation, so they had to convert it to incidence, or they had to convert it to morbidity, which is just new cases over the exposed population, as we've seen before. But since it was a small population, and since it was they figured that it was more complicated and it would be more accurate to use a Bayesian method, which basically just took into account variance in determining the morbidity. But yeah, they decided the Bayesian method was better, even though it's similar means, just a little more complicated. So in the graphs on the next slide, the first one is non-interpolated, and the second one is interpolated with Kringen method. As you can see, still a concentration of cases in the south, but in the spatial distribution map with pinging, you can tell that there's very specific areas of high concentration, which the authors actually used to infer that spatial risk factors could have been the attributes of these areas of high morbidity, as the rates were not uniform. Okay, so the processing of risk factors, as I was talking about, when they were making these inferences, they also used the Pearson correlational coefficient and comparing the density of these dangerous service facilities that they drew from other studies of the bath centers, the beauty salons, and the massage parlors, and the pedicure parlors, which they found positive correlations for all of them. As you can see, the massage parlors found the highest correlation. On this graph, it details, or on these 4 graphs, it details the density of each of the at-risk service, or the risky service institutions. And as you can see, the graphs are actually pretty similar to the interpolated graph, or the non-interpolated graph, but they actually tested this with a correlational values. So in conclusion, there was a positive correlation between the service establishments and the morbidity rate for the disease. An uneven concentration of cases and exposure correlate, especially in the South and the Southwest, which were the economic center regions. They concluded that measures must be taken to reduce the risk of developing hepatitis B at these high-risk facilities, and it must be investigated further why the correlation was not higher if the high-risk facilities were the central issue. So limitations that I found in the study, the population distribution of Shenzhen is not uniform. In fact, they didn't include this, but there's a much higher population density in the south, which they didn't account for. Additionally, they only measure chronic hepatitis B as seen in the first graph that I was presenting, which is much less common in adults. So that could greatly skew the data, as it's really only talking about service institutes that would not affect kids. Also, there's a lack of temporal data, which basically means that over time it was a cross-sectional data study, so they couldn't. There were several limitations that they could not hurdle. That could be, and they were talking about how they wanted to include temporal data in the future, but they didn't have the funding or the resources to do it at the moment. Along with this, the lack of direct correlational data between the patients and the usage of the high-risk facilities. Basically, they used density when they could have, in the future, if they had more resources and contact with the patients, they could have fill out questionnaires. That wouldn't be a cross-sectional data study, but perhaps in the future they could ask about usage of these facilities specifically from patients. But the only contact that they had with the patients for this study was the release forms for their personal data. And then finally, my references. I included the first reference in AMA, American Medical Association typing, and then I included the rest of the links. But thank you.